steroid or glucocorticoid induced osteoporosis.
Thank you, ma'am and sir, for the nice introduction. Thank you, Puneet, for asking me to present on a very interesting topic, which is glucocorticoid-induced osteoporosis. I especially thank my previous speakers for a wonderful talk. So this is the overview of my presentation. I've got two cases. We'll discuss the background of GIOP and bit of pathophysiology. I will discuss the guidelines and clinical trials and a little bit of unmet needs, what we are facing with GIOP. So in terms of the first case, so he's a young male, 56-year-old male with previous history of SLE for last 15 years, with other medical history of diabetes, hypertension, dyslipidemia. He was treated elsewhere. He was very non-compliant with medications, had sporadic follow-up, lost multiple clinical follow-ups as well. He had multiple hospital admissions in the past, had been taking long-term steroids for more than 10 years with various doses, was admitted in ICU with worsening shortness of breath, oliguria, polyarthritis, was diagnosed with SLE, lupus nephritis, myocarditis, and heart failure. So it's a very, very severe lupus. This is the blood pictures. So he had pancytopenia, deranged liver function, kidney function, myocarditis. So we treated him with pulse methylprednisolone, cyclophosphamide, and when stabilized, he was transferred to ward. Now, when transferred to ward, he mentioned about low back pain, and the X-ray showed L1 partial collapse. So again, he self-discharged when he slightly felt better, and there was no follow-up whatsoever. He was discharged with prednisolone, standard SLE medications, what we normally prescribe. The kidney function was slightly deranged. EGFR was around 35-ish. So we couldn't take the DEXA scan because in our hospital, DEXA was not done at that point. So we did vitamin D supplementation. Both teriparatide and denosumab was discussed. But he finally agreed to start off with denosumab. But again, he was out of the radar for many, many years. So almost a year later on, he again got admitted with a SLE flare. But at that point, back was reasonably stable. He denied any focal neurology, but he developed multiple vertebral fractures. But as expected, he never started denosumab. Because he had a background of CKD, MBD was excluded, parathyroid, phosphate, everything was within normal limits. He was taking vitamin D supplementation. He refused teriparatide again, but this time denosumab was commenced. Again, 6 months down the line, he admitted with severe back pain, and X-ray confirmed multiple vertebral fractures, which you can see. And this time spinal surgery was advised because he has some spinal compression, but again he declined surgery. He was almost bedbound with very poor mobility, but once again he self-discharged. Again, almost 6-7 months down the line, he had a very severe hip pain. X-ray confirmed right hip fracture. He was struggling to weight bear. X-ray confirmed fracture neck of femur. He was admitted. He underwent hip replacement. But his bones were so fragile at that point, when he was being transferred from post-surgery from the OT to the theater bed, he developed shoulder pain and a bit of a chest pain, and that confirmed left shoulder fracture and rib fracture as well. So bones were so fragile. So this is a young gentleman with SLE, multiple other medical disease, with prolonged use of steroids. Had multiple vertebral fractures, right hip fracture, right humerus fracture, and left humerus fracture, and multiple rib fracture. So what are the main concerns? So this is a young male with very poor compliance with follow-up and medications, multiple risk factors including SLE, steroids, long-term steroids, renal disease, poor mobility. So all adds on to the risk of osteoporosis. What was the therapeutic challenge? It was poor compliance, renal disease, finance, because he was not the sole earner of the family. So he was dependent on his brothers to finance her treatment. Worsening frailty, and poor because he was a vegetarian, so diet intake was not very reasonable as well. Now, so this is case 2, a young female. Again, she had rheumatoid arthritis for the last 3 years. She was treated elsewhere with tofacitinib, which rheumatoid was reasonably well controlled, and on steroids for a long term. So 5 years, for maybe more than few years. Suddenly, she presented with hip pain. So when she had a hip pain on the right hip pain when he was trying to stand, and then experienced both hip pain, and this was the X-ray. Any comments? I think the orthopedics is a. Any comments on this? Yeah, it's a fracture in the right hip, and when we explored further, there's also impacted fracture on the left hip as well. There's a young patient on rheumatoid, on steroids, had spontaneous bilateral hip fracture in one go, which was non-traumatic. So literally standing, felt a pain, and then extracerebral bilateral hip fracture. So as for young patient, we investigated for secondary osteoporosis. Everything was pretty much clear. Even the endocrine screen was negative. The DEXA scan was performed few months ago, which showed nearly borderline osteoporosis, and the FRAX assessment was very, very low risk. So that clearly tells us FRAX is not perfect, because even in bone density, we only pick up the kind of bone density, not the bone quality. So we are not doing, I won't say justice, but we are not doing enough to get the diagnosis right. So what are the concerns of these patients? So again, the rheumatoid arthritis with long-term steroids and PPI. PPI is also a risk factor of osteoporosis. Bilateral spontaneous hip fracture, no history of falls, and DEXA showing borderline osteoporosis, although she was treated with bisphosphonate and calcium vitamin D. But in the FRAX assessment showed low score, but again, yet she had a bilateral hip fracture. So let's talk about GIOP. So glucocorticoid increases bone loss, reduce BMD, and increase fracture risk. As Dharmanand sir also mentioned, up to 30-40% of patients will have vertebral fracture at some point. And the major losses in the trabecular bone, and the most important time for the kind of this osteoporosis is initiation of 3 to 6 months of starting of treatment. And heavy steroid users, which is more than 15 milligrams of prednisone equivalent, or the cumulative dose more than 1 gram, they are at higher risk. And almost similar range, the risk factor of fracture is nearly 7 times compared to normal, and up to 17 times compared to normal population of spinal fracture. So we always talk about the oral steroid. So what's happened to the inhaled steroids? There's quite a bit of debate in it. So effect of inhaled steroids, what previous studies have mentioned, if it's for a lower dose for 2 to 3 years, it's probably safe. But if it is for a higher dose and for a longer period of time, that causes osteoporosis. But having said that, there's quite a bit of publications that even with low dose inhalation can cause steroid-induced osteoporosis. But for oral supplementation, up to even very small dose like 2.5 milligrams can increase the risk of fracture. So another study, they have studied the effect of various risk factors on GIOP with osteoporosis. And they have found hip fracture probability in women with fixed BMI, that is less than 25 BMI, is from 2% in 50 years old without any clinical risk factors to up to 80% with multiple risk factors, including kind of fibrillary fracture. So this is significantly high. And as I told earlier, when you start steroids, the bone loss usually happens within the first 3 to 6 months. So in this study, they have showed the bone loss has significantly gone down after initiation of steroids up to 20 weeks, which can improve but may not reach the baseline if the proper supplementation is or the other risk factors are not controlled. So what happens with osteoporosis? There is decreased trabecular volume, decreased trabecular numbers, the horizontal and vertical struts are lost. There's loss of parenchyma, so the bone strength is lost. So the bone becomes more porous and more susceptible to a fracture. Again, another study, they have extrapolated data from 2 RCTs, including 306 patients, 197 on risedronate and 111 on placebo. They followed this patient for 2 years, and they looked at the incidence of vertebral fractures on steroid users and non-steroid users. And they have found the fracture risk is higher in glucocorticoid users, always higher compared to the non-users in any range of BMDs. Another studies, they have studied the all inflammatory rheumatic disease, and what is the effect of steroid treatment and when they have treatment for osteoporosis. So they have included more than 884 women and nearly 1,700 controls. They followed for 6 years, and they're also treated for osteoporosis. In the steroid group, they have 4 groups. So one was more than 5 milligrams, one was 2.5 to 5 milligrams, one was 0 to 2.5 milligrams, and was normal, just controls. And at the end of 6 years or range of treatment, you can see in the 5 years group, this loss of bone BMD is much higher compared to others. Interestingly, even in the control group who were on steroids, the BMD loss was quite significant. Now, after treatment, you can see in other groups, like anyone who receives steroids less than 5 milligrams, there's a reversal. That means when you treat osteoporosis, the bone density has increased significantly. But in the patients who receive steroids less than 5 milligrams, probably the bone density improvement, the prevention of osteoporosis are not that significant. And that also portrays to the high fracture risk in patients who are receiving more than steroids more than 5 milligrams. So they concluded the steroids as low as 2.5 milligrams were associated with BMD loss in inflammatory rheumatic diseases, which is preventable probably because when you start treatment, the bone density improves. And bone density loss in patients more than 5 milligrams is not probably preventable. And again, the fracture risk is very high in patients who are receiving high dose of steroids. Another landmark trial, which is quite significant for rheumatologists, because many patients with rheumatoid arthritis, we struggle to control the disease with standard DMARS regime, and we probably recommend very low dose of steroids for a long period of time. And Gloria trial, they have studied those group of patients who are receiving low dose steroids for maybe around 2 years, and they have found there is significant improvement of rheumatoid activity, and especially for elderly patients more than 65, and reduction of joint damage. There's obviously trade-off is when you use steroid for a long time, the side effects risk is higher. But what happens to the bone health when we're using steroid for a long time? This study showed there is very small difference in the bone health BMD markers. Although it was significantly lower in spinal BMD, but in the hip BMD is not that significant. So there's various risk categories of GIP which has been already discussed by previous speakers, so I'm not going in details. So what is the pathophysiology of GIOP? So the various quadrants are affected, can affect the bones, neuroendocrine systems, calcium metabolism, muscular system as well. So in terms of muscles, with prolonged use, there is muscle atrophy, so muscle wasting, muscle weakness, a high risk of falls. In calcium metabolism, there's decreased absorption from gut, increased excretion, so the calcium level goes down, which cause PTH levels to goes up and cause bone loss. Neuroendocrine again manifests in various ways, which causes low bone mineral density. When we talk about bone, we usually talk about osteoblast and osteoclast. That means the osteoblast levels are lower, apoptosis, and osteoclastogenesis is probably promoted, so that causes bone loss. So what's happening with the osteophytes? So osteocytes. So you can see these are usually they work on sleeping cells, but usually they are quite dynamic because in osteocytes, in physiological conditions, they get demineralized, and when the condition settles in the remodeling phase, they get mineralized, and the lacuna, there's a gap in around this osteocyte, so periosteocyte of bone loss. But in the physiological state, the lacuna gets filled and the bone strength is maintained. But in the pathophysiological state, like low calcium state, probably in GIOP, because of prolonged steroid use, there is an osteolysis around the osteocytes, which if it's not treated properly, the lacuna may remain, and that can add on to the osteoporosis, porous bone. So various genes have been discussed in various diseases, even genetic expression in osteoporosis, GIOP is coming in a big way. I'm not going in details. So what are the guidelines? How do we treat GIOP? The various guidelines which are stated, management of osteoporosis, like national NOG guidelines in UK, American guidelines, British guidelines, Canadian guidelines, osteoporosis. There's quite a bit of variations in between these guidelines. I have just chosen ACR guidelines GIOP, which is quite comprehensive, and they have dealt with most of the relevance what we need to know and how to treat our patients. As the risk assessment has been discussed by Thomas sir, I'm not going in detail. So only thing what we say is, for white population, when we do a fracture assessment, the major osteoporotic risk factor more than 20% and hip fracture more than 3% is probably relevant for white population as an intervention threshold. But for Indian patients, MOF is more than 10% and hip is more than 2%. But having said that, if you have a look, in fracs, we can't use the steroid dose, but only whether the patient has received steroid, yes or no, we can put in. So that probably underestimates the risk. And this fracs assessment can be overcome, this kind of deficit or limitation, by fracs plus, which sir has already mentioned. But when you use steroid for a longer period of time and higher dose, if it's more than 7.5 milligrams daily, you need to have a fracs GC steroid correction. So you have to add on the major osteoporosis risk factor by 15% for spinal risk and hip by 20%. So that will probably give you an estimate. So in terms of fracture risk stratification after fracture risk, so it has been earlier mild, moderate, and high low in terms of major osteoporotic risk factors. If it's less than 10, it's low. If it's 10 to 19, it's medium. So more than 20 is high. But in the recent guidelines, in 22 guidelines, they have come up with a very high risk patient who had previous osteoporosis fractures. BMD is very low, less than 3.5. And the GC adjusted fracs major osteoporotic risk factor is more than kind of 30%. And they have been very high dose of steroids, like more than 30 milligrams for a long period of time, more than 30 days, or more than 5 grams. All this group of patients very, very high risk of fractures. So with that in mind, what are the treatment recommendations? This is a very busy slide, so I'll keep it very simple. So overall, if it's a very high risk patient, probably start off with teriparatide, which has been recommended. Or you can use denosumab or other IV oral bisphosphonates. If it's a moderate risk, the conditional recommendation is either denosumab or teriparatide or oral IV over oral. If it's a moderate, you can choose whichever you want. You have various drugs on the plate. If it's a low risk, that means the fracs assessment is very low, either more than 40 years, or if it's less than 40 years, you can't use fracs. In those patients, probably have to monitor those patients regularly. So probably you can do either fracs assessment or BMD every 2 to 3 years and kind of risk stratify them. And if the risk changes, becomes much higher, then you always treat them. So what are the recommendations for initial treatment failure? So if somebody is on treatment, again, if they have a fracture or BMD goes low or the bone markers is rising, then you have to really step up. If you're using oral bisphosphonate, you can use intravenous denosumab teriparatide. If you're using raloxifene, then probably go for bisphosphonates. If you're using teriparatide already, then you can either resort to denosumab or romosozumab, which is already in India now. Or if you're using denosumab, probably you can try intravenous zoledronic acid. The crux is, if you're on denosumab and if you go on teriparatide next as a sequential therapy, the bone density suddenly drops in the hip, and there's a more risk of hip fractures. So what are the strategies for sequential therapy when patient is on having osteoporosis and their steroid is discontinued? So what happens next? Should you continue treatment or not? So in high risk patient, where patients remain in osteoporotic range or they have further fracture, either you continue therapy or you resort to other antiresorptives like either bisphosphonate, denosumab, teriparatide. But in low or moderate risk patients where steroid has been stopped, so what shall we do? So if this patient is on either oral medication or raloxifene, you can always stop it. if patient is on parathyroid, teriparatide, or denosumab or romosozumab, because the bone retention is very poor, so bone retention is only high in bisphosphonates. All these other group of drugs like denosumab, teriparatide, or kind of romosozumab, their bone retention is poor. So when you stop treatment, you have to have a plan B, like some anti-resorptives, like denosumab or bisphosphonates, to maintain the bone density which has been gained by previous treatment. So what are the recommendations for special population? For young adults, if they're for a long-term treatment, like or very high dose of steroids, usually you have to resort to treatment like bisphosphonate, oral, IV, denosumab. If it's a very young patient, so 4 to 17 years, and risk is not very high, you can stay away from treatment, but vitamin D, calcium supplementation is always recommended. But again, even in young patients, like ped patients who are on high dose of steroids, you might have to start treatment. So what happens to the pregnant patients? So there's always a concern about fetal toxicity, but it's quite safe. If pregnant patient is having a fracture, then you can start oral or intravenous bisphosphonate, teriparatide. There is a question about denosumab, because the fetal toxicity is probably higher. In CKD patients with EGFR less than 35 or less than 30, is always better to assess for the CKB MBD, so that there is no adenemic bone disease or renal osteodystrophy. But if the EGFR is reasonable, then you can start any of those doses, like either bisphosphonate or probably denosumab or teriparatide. Shouldn't be any dose reduction. So these are the considerations for steroid-induced osteoporosis in the newer guidelines, which I've already discussed. The few studies, which is better in GIOP, whether teriparatide or alendronic. This study has showed teriparatide is definitely better than alendronic acid in terms of increased bone density in spine and hips and the fracture efficacy. Again, if you compare denosumab and risedronate has fared better in terms of increase in bone density compared to risedronate, and the fracture risk is also better. This is a fairly new study. They have compared the efficacy of denosumab and romosozumab in steroid-induced osteoporosis, and they have found comparable efficacy, but there is a kind of glitch in the study, because most of the patients who received romosozumab, they have received some form of anti-resorptives earlier. So when you receive anabolic agent after anti-resorptives, the effect of anabolic agent is often lost. So that could be one of the reasons why the efficacy was lost in this study in romosozumab, which is a very probably one of the best drugs what we have at the moment. Again, UK guidelines is not kind of dissimilar to the ACRs, pretty much similar. Very subtle differences in between two guidelines. Now let's come back to our case. First case, young male who had multiple fractures and on medication, although the complaints was a question. So when would you define somebody to have a treatment failure? So if someone has more than 2 fragilative fractures, or 1 fracture with significant change in BMD or inadequate response to bone markers, or no fracture with a significant decrease in BMD or suppression of bone markers, which Puneet has already mentioned. So what we did to our first patient, so we tried combination therapy, as sir was alluding earlier, and we were concerned about the compliance and the financials, but finally patient passed away during the COVID time, because he has severe COVID infection as well, because he was immunosuppressed. But why we used combination therapy? So if you look at the data switch study, they have compared 3 groups. One is the combination therapy using denosumab and teriparatide for 2 years, followed by 2 years of sequential therapy with denosumab. Another group, teriparatide first, followed by denosumab. And the third group, denosumab first, followed by teriparatide. And they have found the combination group, their efficacy is probably better in terms of both spinal and hip bone density, but they haven't assessed the fracture efficacy properly. So let's come back to case 2. So what we did, so this patient, a young patient with had bilateral hip fractures. He had both hip replacement. Adequate vitamin D and calcium supplementation was done. and it was comments of romosozumab. We probably have considered romosozumab in a first patient as well, but that was not available at that time. So what are the unmet needs? I'm nearly coming to an end. So as we discussed earlier, what is the peak bone mass acquisition? That's already fixed for most of our individuals, but patients who are at SLE or rheumatoid arthritis or long-term steroids at earlier age group, probably their peak bone mass is already low to start with. So as that age progresses, they plunge into osteoporotic range very early, and that have these consequences. And about the diagnosis of osteoporosis, bone density versus bone strength or bone quality always remains a challenge, because we only do DEXA scan. Very few centers can do bone quality assessment. Probably that holds significance for our second patient, because the fracture risk was high, bone density was normal. Only few months ago, yet she had a bilateral hip fracture. Now, fracture risk assessment, whether increase in bone density, what we are suggesting or what we are expecting from anti-osteoporosis therapy, whether that relates to increase or decrease in fracture efficacy. That not necessarily mean if the bone density is increased, that relates to decrease in fracture occurrence. Again, fracture liaison service is a challenge, especially in private sector, because there is a need to liaise with the orthopedics, endocrine team, various other teams, so that we can identify patients and risk and prevent further fracture. There are a lot of guidelines with osteoporosis, but there's a lot of variations in between them. So probably try to adopt one and do the best practice for your patients. And obviously drug side effects. When you use them for a long term, chance of atypical fractures, osteonecrosis, jaw is there. But you have to weigh the risk and the benefit and offer treatment which is best suited for your patient. To conclude, which has already been discussed many times, so osteoporosis always remains a major challenge for steroid use, but appropriate risk stratification, appropriate treatment management for the patients is essential, not as an initiation of therapy, as a sequential therapy or combination therapy if needed. Lifestyle modification like calcium supplementation, regular exercise, falls prevention, they're all equally important. Cost-effective therapy, because romosozumab is probably the best therapy what we have now, but whether how many people in India can afford. So that remains a question. Even for teriparatide, many people can't afford. Probably that's one of the better drugs. Again, fracture liaison would be quite useful to have if it's is there. That will help our patients. Thank you.
Thank you, Dr. Parthajit, for the excellent overview. I think we will not be able to take any questions because we are very much behind the